One of the things that people ask me a lot is, what is a total knee replacement for? And what kind of pain is a total knee replacement designed to take care of? Really, the answer to that question is pain from osteoarthritis. So there's a lot of different things that can cause pain in people's knees, and there's a lot of different places that that can be from. Osteoarthritis specifically is a wearing out of the knee joint, essentially. I like to think about it as treads on car tires. As you wear down the treads on your car tires over time, the tires get less and less effective and they don't work as well. Same with the knee. As the knee wears down over time, especially the cartilage in the knee, as that wears down, the interface of the knee joint becomes less smooth, it becomes inflamed, it becomes irritated, and that causes people pain. That pain is something that's felt in the knee specifically. There's a lot of other kinds of pains, for example, back pains, pain from the spine, that people can feel in the knee. Often that will radiate down past the knee or into the foot, and that is not something that dealing with the knee can particularly help. One of the ways that I assess for this is I listen to people talk to me about their pain, and they describe it as they describe this pain in their knee that gets worse whenever they're walking, whenever they go up and down stairs. When they sit for a long period of time, the knee gets stiff and painful and uncomfortable. Those are all things that sound like osteoarthritic pain. We also do more than just listen, though. We get x-rays and we look at the knee joint as well and see, is the knee joint worn out? Is it losing joint space and becoming deformed and worn away? We do not start treating osteoarthritis of the knee with a total knee replacement. That's the end of the road. That's after everything else has failed. The first thing that we do is try and keep people moving their knees and exercising their knees. Joints are made to move, and so moving joints are happy joints, and will keep the joint itself as healthy as long as possible and moving for as long as possible. The native knee and trying to preserve the native knee is a huge part of my goal in treating osteoarthritis. I can put in a good knee, but I can never put in a knee as good as the one that God put in. And so keeping that knee going for as long as possible is very high on my list of goals. The first thing that we do with that, as I said, is exercise. Sometimes that becomes a little bit difficult for people and a little bit painful for people, for things like walking or running after their knee starts to wear out, and that's a hard sell. There are some things that I really like pool exercise, that I think is very helpful in keeping people's knees strong without putting quite so much stress on them as walking around after the knee starts to wear down. If that doesn't work, the next thing that we like to move up the ladder of treating osteoarthritis is oral anti-inflammatories. So things like ibuprofen, Advil, Celebrex, these things can be very helpful in helping to reduce the inflammation in the knee joint that comes about because of the wearing out, the wearing down, and helps to control the pain. Now, there is nothing that we can do to reverse the process of osteoarthritis. Once the cartilage is worn away, just like treads on the car tires, there's nothing that we can do to unwear the tires. But we can reduce the effects from that wear, especially the inflammation. If oral anti-inflammatories aren't quite cutting the mustard, the next place that I go is to think about intra-articular corticosteroid injections. Those can be very, very helpful in some people in helping to reduce their pain and reduce their symptoms, and again, to keep them moving with their native knee for as long as possible. Once steroid injections are also not helping people get the relief that they need and stay active the way that we want them to stay active, then at that point, we start to think about a total knee arthroplasty. This is a decision that is completely driven by a person's symptoms and their activity and their goals of activity. I do not put a total knee in or even talk about putting a total knee in with somebody until it's getting to the point where they are not able to perform hobbies that they want, right? Being able to spend time with their grandkids, being able to go up and down stairs without tons of pain, being able to garden, things like that are normal and realistic goals that people should be able to achieve. And once they start having to give up on those things, at that point, I think that it's reasonable to start asking ourselves, should we consider a total joint arthroplasty for the knee? What is a total knee arthroplasty? Sometimes we call it a knee replacement. I've got a model here of exactly what a replaced knee looks like. And so here we have cobalt chromium components and very fancy plastic on the tibial side. Before we put these components in, though, I'll show you what we do is we make very, very special cuts for these components to sit against. And you can see that the many parts of the knee are left, right? So like these, the collateral ligaments on each side are left to help keep stability in the knee. This is almost a resurfacing of the knee, is to take out the damaged surface and the worn away surface in a very specific way with very specific cuts. And then to resurface that with metal and plastic, just like so. Once we get these in, the patient is given a very stable knee, a knee that is not a worn interface with a worn interface, something that's rubbing and grinding and causing them pain. It's a much smoother thing. And they're able to go about and do, again, the normal things that we want people to get back to. Walking, going up and down the stairs, being able to do hobbies, that kind of thing. So the first thing that we do is we open up the knee, and there's a lot of areas of bone spur and osteophyte and worn out areas. And I clean all this out. We get all of the osteophyte out of there. And then I make very, very specific cuts, right? These cuts here, so that I can place the implants into the knee in a very stable fashion. These cuts, I want them to be perfect. Right? I want these to be down to the millimeter of accuracy and just within a couple of degrees or so, depending on how I want this knee to be balanced. So I use very special cutting jigs so that I can make my cuts very, very accurate. And I'm very, very critical intraoperatively of how good these cuts are. This is really important to me. And this is something that I target to each individual patient in the operating room, is to make these cuts perfectly for this patient and for this knee that is here today. It's not the same cut for everybody, and it's not the same implants for everybody. The entire goal of a total knee arthroplasty is to give somebody a good, functional, and well-balanced knee at the end of this surgery. And I do a lot to try and make sure that that knee for this patient is as perfectly balanced as it can be. I make the cuts very carefully. Once I've made the cuts, I go in and I put in what we call trial implants, which are not the final implants, of various sizes to see which size is going to be perfect for this patient. And if a size is too loose, then I try a size up or a size down, so on and so forth, to get a knee that's not too tight. I don't want a knee to be stiff for a patient, but I also don't want it to be too loose and to be unstable and for them to have a sloppy knee at the end of all of this. And so I trial the components until it's a absolutely fantastic knee. And then once that decision has been made, then we open up the final implants, which are the implants that no other patient has ever had implanted into them, have never been used on another patient. They look sort of like this, but these are obviously just models. And I cement them onto the very special cuts that I've made and retrial the knee, be sure that everything is exactly the way that I want it to be, and then we close everything up and the patient wakes up later that day. That's how the total knee surgery goes. After a total knee surgery, I want people to be moving as soon as possible, essentially, especially trying to work on getting full extension and being able to weight bear. Those are things that people can do as soon as they wake up from surgery. I usually do surgeries early in the week for total knee arthroplasty, and then I plan to have people going to physical therapy and attending physical therapy early the following week, so within 7 days, to start working on weight bearing, gait training, range of motion, those kinds of things. One of the things that we concentrate a lot on in the early post-operative visits is making sure that people are regaining full range of motion. That's a thing that's much easier to get sooner after a total knee arthroplasty than to get later. For example, if people get stiff or get contractures in their knee months and months after surgery, that's a more difficult problem to solve. Getting full extension especially is something that's very helpful to be very persistent about while people are recovering from a total knee. After the surgery, I send people to physical therapy to start working on their knees and working on rehabilitating their knees very quickly, within 7 days. Getting range of motion back in the knee sooner than later is very, very helpful for people's outcomes and for their experience with the knee. If the knee gets stiff and people get a contracture, that is very difficult to deal with once you're several months out from the surgery. And so I like to be very aggressive with physical therapy and moving the knee right away and having people weight bear on their knee right away. That I find is very helpful with getting people back to these normal activities that are the goal of the surgery much sooner. It's my goal for people to be walking and carrying out these normal activities, being able to get around their house and that kind of thing within 6 weeks or so. Patients are very, very different after a total knee arthroplasty. Now, the pain in the knee decreases differently for everybody, and this is something that can take anywhere from weeks to months depending on the patient.